Well, I want to thank everybody for tuning in today. We have about a 15-minute talk on my aching knee, and we're going to discuss some very common knee problems and some treatments and when to seek evaluation by either your primary doctor or maybe orthopedic doctor. So I'm here at our office at the Bay State Health and Wellness Center in Northampton and currently doing surgeries at Bay State Franklin Medical Center in Greenfield, as well as some surgeries in Springfield as well. So knee pain is one of the most common reasons people end up going to the doctor. It's actually the second most common reason behind skin disorders for why patients make appointments. A lot of problems can be prevented or treated with very simple measures, and of course, some problems end up requiring surgery. The knee is the largest joint in the body, has a lot of degrees of motion, and it's vulnerable to injury, and many kinds of things can go wrong. We'll start with just a little bit of the anatomy and what is made up of the knee, and it includes bones, cartilage, ligaments, and tendons. So you can see here on this illustration, there's three main bones in the knee. That includes the femur, which is the largest bone in the body. And then the end of the femur, you have cartilage. The tibia is the bottom bone, and there's cartilage at the top of the tibia. And the patella, or the kneecap, sits in front of the knee. There's cartilage, which is a slippery substance that helps your bones glide smoothly. And then between the cartilage at the femur and the tibia, we have the meniscus. There's a medial meniscus on the inside portion of your knee and a lateral meniscus on the outside. These are cartilage pads that act as shock absorbers to help distribute force in the knee and provide knee stability. In addition to the meniscus, we have the ligaments around the knee, and there's four ligaments. There's the anterior cruciate ligament in the front, the posterior cruciate ligament in the back, the lateral collateral ligament on the outside of the knee, and the medial collateral ligament on the inside. So there's many reasons for why patients get knee pain, and some of the most common complaints, which we'll focus on today, include these top two reasons, which are osteoarthritis and meniscus tears. Other acute injuries such as ligament tears can commonly occur as well, but not as frequently as these first two diagnoses. So osteoarthritis is simply the gradual wearing away of the cartilage. It can occur in any joint, and it's the most common form of arthritis. There's other forms such as rheumatoid arthritis and other sorts of inflammatory conditions. But in general, when people are discussing arthritis, they mean osteoarthritis, which is the gradual wear and tear. And as the cartilage wears away, there's less cushioning and less ability for the joint to act as a shock absorber and distribute force across the knee. And eventually, once all the cartilage is gone, we get bone-on-bone arthritis, causing even more pain and loss of motion. So here's an x-ray of a patient. This is their left knee, someone that has a lot of arthritis on the inside portion or the medial portion of the medial compartment. You can see here's the femur, here's the patella, and here's the tibia. And on the outside portion of the knee, this black area is where the cartilage exists. And this patient still has preserved cartilage, but then going on the inside or the medial compartment of the knee, we have bone-on-bone arthritis and complete loss of cartilage. This is also seen in this live surgery. So this is a left knee as well, and you can see the cartilage here remaining on the outside portion of the knee, that slippery, glistening, smooth substance, which allows the bones to glide together pain-free. And then here on the inside, this is where all the cartilage has eroded, and we're seeing the subchondral bone below. Some signs of osteoarthritis include pain or aching, stiffness, decreased range of motion, as well as swelling. So this is looking at the front of the patient. You can see their left knee, the normal appearance, and how swollen the right side is. And when we have osteoarthritis, there can be phases and periods where the knee is very swollen, painful, achy, and then can gradually diminish, and there can be injuries or sometimes weather changes or reasons for why the knee becomes painful and swollen. And there's lots of treatments that we can do to try to diminish that when it does occur. There's several risk factors for osteoarthritis, and some of those we have control over. Some of those are out of our hands. Older age is a risk factor. As we get older, our risk for arthritis increases. Gender is a risk factor. Women are at higher risk for arthritis as opposed to men. Obesity is one of the modifiable risk factors as we have increased weight that puts increased stress on the joints, accelerating the arthritic process. Injuries to the joint can predispose you to arthritis, and that can include knee fractures. And that's what this picture is showing is a fracture of the intra-articular tibia. This bone should be here, and there's also a fracture of the fibula bone. And, despite probably needing surgery and piecing this fracture back together, just having an injury like that, or even much less severe injuries, any kind of involvement of the cartilage or a fracture that it goes into the joint is going to increase your risk for that. Meniscus tears or ligament tears or any kind of damages to the cartilage will also increase your risk for post-traumatic arthritis. Repeated stress on the joint, whether from your occupation or your activity level, will increase your risk. So people that are high demand occupations for 30 or 40 years are certainly going to be at increased risk as opposed to someone who's working at a desk job. And even patients who are involved with high impact sports such as basketball, running, downhill skiing, where they're kind of putting a lot of force on their joint and also increasing the risk for injury will increase that. There is a genetic component as well as certain bone deformities. You can see this patient has varus knee alignment or knee bowing versus more kind of standard alignment on this other picture. So a patient with knee alignment like this is going to put more load on the inside portion of their knee, increasing the risk for medial compartment arthritis. Certain metabolic diseases can also increase your risk factor, but that's less common. Another very common cause of knee pain besides arthritis is meniscus tears. And we briefly mentioned the meniscus act as shock absorbers, transmitting forces across the knee joint. They also act to provide stability to the knee. We can see this is a picture from arthroscopic surgery for the knee. We can see the femur bone on top with normal appearing cartilage, the tibia on the bottom with also normal cartilage, and this cartilage pad known as the meniscus, which is intact. This picture on the right shows a patient that now has a meniscus tear and a complex tear pattern. These are among the most common knee injuries, and they can occur acutely from simply twisting, standing wrong, or falling, or more commonly can be a degenerative type process that occurs along with osteoarthritis. There's several types of meniscus tear patterns, and we won't go into too much detail, but in general, certain tear patterns are repairable and other tear patterns are not repairable, and it changes kind of our treatment options and how we decide on when to do surgery versus when to try some non-operative treatments first. So this is kind of a meniscus showing all the different ways that it can tear. This picture on the bottom is showing a specific tear pattern called a bucket handle tear, where a piece of the meniscus can be flipped into the center of the knee and can cause catching and locking and what's known as mechanical symptoms. So the symptoms of a meniscus tear can be very similar and sometimes hard to differentiate from arthritis. They include pain, stiffness and swelling, catching or locking of your knee, or the sensation of your knee giving way. There can also be a block to motion, which is not so common with arthritis. And this is another arthroscopic picture. You can see LFC is the femur, or the lateral femoral condyle. This is the ACL, or the anterior cruciate ligament, in the front of the knee. And here's what's called a bucket handle meniscus tear. This is that meniscus that's now flipped out of position, sitting in the central part of the knee. And when patients have these kind of tear patterns, they cannot fully extend their knee. And these are often types that are not going to get better without surgery. So in general, most tears are degenerative and not associated with acute traumatic injury and kind of occur over time gradually, and they have poor healing potential as they have limited blood supply. Um, there is some tear patterns, however, that can heal, and we'll touch base on that. And then another reason why these tears hurt is they can upset the lining, which is also known as the synovium of the knee. This lining, when it's irritated, can release inflammatory proteins. There's also nerve endings that can get inflamed, irritated, and cause more knee swelling. So here's a picture of this kind of red, frayed appearing tissue is the lining of the knee, which is inflamed synovium or synovitis, and more in the background, the synovial tissue appears more normal. And not all tears are going to be painful or need treatment. Sometimes tears can be symptomatic for a few weeks, and then with some simple treatments can resolve. Other tear patterns that have unstable flaps that are floating around the knee and changing positions, irritating the surrounding structure of the knee can be more symptomatic and oftentimes not improve with conservative management. And if you have certain symptoms such as buckling, instability, catching or locking, you may benefit from arthroscopic surgery as opposed to some of the other non-operative treatments if you have more just pain or pain not in the vicinity of where your meniscus tear is located. I want to comment on just a specific kind of tear called a meniscal root tear. So the meniscus root is where the meniscus attaches in the back part of the knee. So here's the meniscus, here's again the femur and the tibia, and this is the meniscus root avulsed off of its normal attachment. So normally it should be kind of sitting here, and patients with meniscus root tears are going to present more acutely with immediate and intense pain, sometimes in the back of the knee. You may hear or feel a pop when this happens. Simply, sometimes just standing up from a chair or going down a step is how they can occur. And if you have a complaint such as acute swelling, inability to bear weight, if you're limping, um, those are reasons to call your doctor to get evaluated sooner, because these are one of the tear patterns that we can oftentimes fix. So before we're not treating these surgically or doing meniscectomies, taking away the damaged area of the meniscus, but we're finding out that these are some injuries that we can repair, and patients do well and limit the chances of going on to get worsening arthritis if they go on to heal. And these are fixed by passing sutures through the posterior root. And then these sutures are passed through holes into the tibia and tied down, securing the meniscus root back to a more anatomic position. And then when we have a meniscus tear or a meniscus deficiency, the joint experiences greater amounts of force, and this can lead to arthritis. This is an arthroscopic picture of someone with more advanced arthritis. And if you remember that smooth kind of glistening cartilage as compared to something like this, over here there's still cartilage available, but on here on the outside of the knee, we have that subchondral bone and basically bone on bone arthritis. And for someone like this, their pain is probably more likely coming from the advanced arthritic changes as opposed to a meniscus tear. So certain tear patterns we can fix. Those include the root tears, some bucket handle tears where the meniscus is flipped into the notch and we can actually push it back into a more anatomic position. Certain tear patterns, which are known as vertical longitudinal tears, we can fix when they're located at the outside portion of the knee, as this portion of the meniscus actually has a good blood supply and healing potential. So good candidates for repairs are patients that have certain tear patterns, patients that have minimal arthritis and not advanced bone-on-bone arthritis, and patients that are able to do rehab and sometimes have to be non-weight bearing for about 4 to 6 weeks after the procedure. And for the tear patterns that are not going to heal or have a low likelihood to heal, for those patients, we do partial meniscectomies, basically resecting away the torn area of the meniscus, leaving a stable rim, as much meniscus as possible. So for a tear like this parrot beak tear, if you had something like this, we would go in and trim around the torn area, leaving as much stable meniscus behind, getting rid of those kind of mechanical symptoms, catching, locking, or other complaints that may be associated with it. So I'm going to talk a little bit about the non-surgical management for meniscus tears as well as arthritis, because a lot of the treatments are very similar and work for both conditions. So simple thing to do is maintain optimal weight. Healthy weight would lead to less pressure on your joints, reducing inflammation, and helping you move around more easily. And a lot of people probably don't realize that, but for every step you take, the knee takes on a load 3 to 6 times that amount. And what that means, if you lose even just 10 pounds, it can feel like 30 to 60 pounds of less force onto your knee. Losing weight can also slow the progression of osteoarthritis. Once arthritis begins, there's not very many ways we have in 2022 to reverse or regrow new cartilage, but we do have options to prevent the progression or slow down the progression. And weight loss is best done with a combination of diet and exercise. Exercise has numerous benefits, can help with increased range of motion and function, and more importantly, specifically for the knee, it can strengthen the muscles around the joint, and stronger muscles can support the joint, which means the knee will be more stable and experience less impact with loading. So even if you do have some arthritis around the knee, if your knee is strong and stable, it's not going to feel as much because your muscles around the knee are going to be taking on some of that load, as opposed to the areas where you have bone-on-bone arthritis. And there's several components to exercise, and many of these can be done at home with minimal equipment or at a gym. Includes stretching, strengthening, as well as aerobic exercises. We have some exercises available online through our academy website, known as the American Academy of Orthopedic Surgeons. There's also some links through Bay State for exercises to work on at home. And the goal with aerobic exercise is to move your knee, keep your knee strong, but do activities that are not going to cause more pain, and do activities that you're going to enjoy. So in general, if you have knee pain and arthritis, low impact activities are best, such as walking, biking, swimming, or doing the elliptical exercise. And a lot of this stuff can be done at home without any equipment. But there's also a role for physical therapy, and they can show you how to do the exercises, make sure you're doing good form, not going to get hurt doing the exercises, and also can kind of tailor programs specifically to you if you have any muscle imbalances or any specific areas that need to be targeted. And a lot of times, physical therapy can go on for about 4 to 6 weeks. And in that time, you're also doing exercises at home, and then it becomes more of a home exercise maintenance program. Some other good exercises for strengthening and for patients with joint pain includes Tai Chi and yoga. Also things that can be done at home with minimal equipment. Cold therapy or applying ice or packs to your knee is a great way to help with knee pain, either acute or chronic symptoms that have flared up. And cold therapy works by a few mechanisms. It can constrict the blood vessels to the knee, causing less blood flow, and kind of help reduce that swelling. So that's why ice is good for an acute injury and even for a chronically, periodically swollen knee. So that when we ice our knee, we have less joint fluid, which kind of can help with that swelling and pressure from too much fluid in the knee. And ice also works by distracting the brain. When the joint is cooled, it stimulates the sensory receptors in the skin, and that can help limit the transmission of pain signals, almost blocking those pain signals temporarily, as the signals of the signals from the cold is going to the brain as opposed to the pain receptors. So this could be with an ice pack, or sometimes after surgery, we do these sleeves, which we apply on the knee, and they can circulate cool air continuously around the knee. And sometimes patients will have surgery and put one of these on and then kind of use it as needed after if they have periodic episodes with their knee. The go-to medication, if you can take, is NSAIDs, which stands for non-steroidal anti-inflammatory drugs. Some common NSAIDs, which you've probably heard of or taken, include aspirin, Motrin, Advil, ibuprofen, and Aleve. These medications work by decreasing the pain, inflammation, and stiffness associated with joint pain and meniscal tears. They're inexpensive, first-line treatments, and many forms are available over the counter. They typically are more effective for musculoskeletal pain than Tylenol or acetaminophen, and they can also be used in conjunction with that. They're available by pill form over the mouth, as well as topical formulations that you can rub onto the knee or any other areas that are painful. And the anti-inflammatory topicals used to be prescription strength, but now they're also available over the counter, and the trademark name for that is Voltaren Gel. And there's lots of different varieties of both over-the-counter and prescription. And if you've tried one anti-inflammatory and one NSAID and haven't gotten good relief, sometimes certain medications work better for certain patients, and it might make sense to try a different prescription or consider getting a prescription strength version of the medication. There are some risks associated with NSAIDs, most commonly GI problems. If you're on long duration of NSAID treatment, you could be more vulnerable to pain, heartburn, ulcers, nausea, vomiting, and diarrhea. And every NSAID except for aspirin does slightly increase your risk of heart attack, stroke, and heart failure. So if you have any history of heart disease, coronary artery disease, or heart attack, should use caution and speak with your doctor before beginning any NSAID. Patients can have allergic reactions, and then long-term use of NSAIDs can decrease your kidney function. So the safest way to use is to take it for the lowest dose as possible for the shortest duration of time. Take it with food and water, and make sure you stay well hydrated. And some of the prescription strength versions target specific enzymes, and those can lower the risk of the gastrointestinal side effects. So if you've tried some over-the-counter ones and have had some side effects, might be worth considering switching to a specific COX-2 inhibitor. And there's a few different versions of those which are available by prescription. Glucosamine is a over-the-counter supplement, which is a natural compound found in cartilage. It's a pill you can take daily. If you've ever heard of Osteobiflex, that's the trademark name for glucosamine, and it may provide relief for patients with osteoarthritis, and it may even help slow the degenerative process. Some studies have reported fairly good results, other studies not so good, but in general, it's a safe, low-cost medication with a low risk of side effects, usually gastrointestinal-related side effects. So I look at it as something that may potentially help and not have much downside to try if you're having significant joint pain. Cortisone injections are often another first-line treatment if you come to see your primary care doctor or your orthopedic doctor for knee pain. And cortisone is a synthetic steroid hormone similar to cortisol, which is the natural version produced in our body. This is produced in times of stress, and that's basically how cortisone works. It works to decrease the swelling and inflammation going on in the knee. In general, we're limited to 3 to 4 cortisone injections a year, as too frequent injections or injections that are done too close together may damage the cartilage in the knee. Some other potential side effects with cortisone injections include temporary elevation in your blood pressure and your glucose. So patients that have uncontrolled diabetes or uncontrolled blood pressure should use caution or probably consider other types of treatment. And patients often ask about the cartilage damage in the knee, and I think if you do it carefully and not too frequently, 3 to 4 times a year is probably safe. And other patients, if you have more advanced arthritis, basically arthritis to the point that there isn't any surgeries available besides a knee replacement, then I don't see much risk to getting frequent injections, as the cartilage loss has already occurred. In younger patients or patients that maybe have minimal arthritis, then sometimes we might do a couple injections and then consider some of these other treatments. So another type of injection is known as viscosupplementation or hyaluronic acid injection. This is a very viscous gel-like fluid, used to be made from rooster comb. So that might be something you've heard people talk about. Rooster comb injections is this viscosupplementation. So it's a naturally occurring substance found in the synovial fluid or the joint fluid of the knee, and it's thought to act as a lubricant and enable your knee to the bones to move more smoothly, as well as act as a shock absorber. And it's the thought that patients that have arthritis have less of this hyaluronic acid in their knee, and this can kind of replenish that. Also, there's some anti-inflammatory components to the injections as well. This is a little different than the cortisone injections, as this needs authorization from your insurance before getting approved. And some insurances are not covering this injection, or some may require that you've had a steroid injection or physical therapy or some other kinds of treatment before approving it. And these kind of injections are typically done twice per year. And we also have many patients that get relief from both the viscosupplementation and the cortisone injection. So someone like that might come in for a cortisone injection, 3 months later for viscosupplementation, 3 months later for cortisone, and then 3 months later for the viscosupplementation. So that's a good way to kind of get the benefits from both medications without taking too high of a cortisone dosage. Platelet-rich plasma injections is an even newer treatment known as a biologic treatment for knee arthritis. And platelet-rich plasma, or better known as PRP, is plasma that's drawn from your own blood. So basically, the way that works is that you get your blood drawn in the office, and then the blood is placed into a centrifuge that processes the blood, concentrating the platelets, which contain growth factors that are thought to change the environment in the joint. These concentrated platelets, or PRP, is then injected into the knee joint, similar to how we would with the cortisone or the viscosupplementation injections. And there's still a lot to be researched on PRP, but the literature has supported that can be effective in cases of mild and moderate arthritis, and possibly even better results than cortisone injections without that same risk profile. Currently, this is not covered by any insurance, as they're waiting for more concrete data that it's going to be effective before they pay for that. And the treatments generally range from $500 to $1,000, and sometimes patients will get one injection, sometimes they'll get a few, or similar to the other types of injections, something where they might get every year. So there's a lot of different injections, but most of the time before PRP, patients are going to try something that's covered by their insurance or at less out-of-pocket cost. And then lastly, for patients that have meniscus tears, not so much just advanced arthritis, we have surgery, and the surgery most commonly performed for meniscus tears that are not repairable is arthroscopic partial meniscectomy. And this is an outpatient procedure, usually performed under general anesthesia. It's typically very fast, generally about 20 to 30 minutes. After the surgery, patients can walk with crutches, and the recovery is typically very fast, usually over several weeks. Sometimes patients do physical therapy after, sometimes they feel pretty good and are able to do the exercises at home. So these are just some more arthroscopic pictures showing this bucket handle meniscus tear sitting in between the femur and tibia, causing pain and blocked motion. And then after the bucket handle meniscus is resected, we see this kind of remaining meniscus stable rim. So the kind of the steps to the surgery involve getting put under general anesthesia and then making small poke hole size incisions, typically 2 incisions in the front of the knee. We then insert the arthroscope, or the camera, into the knee joint and assess the meniscus, the cartilage, and all the other structures involved. Through the other incision, or the portal site, we then place our instruments, which include arthroscopic shavers, biters, and various combinations of instruments to resect or remove the torn meniscus back to a stable rim. After the surgery, you have a dressing, you get your crutches, and you go home that same day. Here's just another picture of what a meniscus meniscectomy looks like for one of these flap tears. So here on the left, we can see this unstable flap of meniscus. And as the knee bends, you could imagine this can go in and out of place and irritate the cartilage and the joint fluid. So we go in with our camera and our instruments and kind of resect back along the torn area of the meniscus. And then when we're done, we still have hopefully a good portion of the meniscus remaining. So patients can typically expect significantly improved pain relief, and usually it's very fast improvement in symptoms. However, if patients have more advanced arthritis, which we can usually tell ahead of time based on x-rays or MRI, then they may not have as much pain relief, or they may have partial relief or maybe temporary relief. Sometimes patients that have more advanced arthritis, the degenerative arthritic process continues, and they may go on to need bigger surgery such as joint replacement. So the decision is kind of made on a case-by-case basis, and we discuss what your goals and expectations are ahead of time. And if someone does have arthritis, which is also very commonly seen with meniscus, we just talk about how likely we think surgery will be successful. So if we saw someone this knee, maybe not as much chance for good outcomes, but we do see lots of people that do get relief even with knees that look like this that we do the arthroscopic surgery for. There are some complications after surgery, although it's very low, and usually they're minor. And some of these include infection, blood clots, stiffness, blood or swelling of the knee, as well as bruising. And these can oftentimes be treated easily or just observed for symptom resolution. And then lastly, we'll talk briefly about knee replacement. So for patients that have this very advanced arthritis, bone on bone, that have failed to improve with all of these kind of non-operative treatments that we talked about, like the NSAIDs, injections, physical therapy, or maybe have had a previous surgery and are still symptomatic or have had progression of arthritis, we have knee replacement. And that is basically involved removing the arthritic area of the bone and replacing it with a metal femoral component, a metal tibial component, and a plastic liner between the two. So here's another diagram, just basically showing what's involved with the knee replacement. It involves an open approach, an incision in the front of the knee. We then expose the ends of the bone and use cutting guides to remove the ends of the bone where there's arthritis. And knee replacement, typically the ligaments in the meniscus are removed as well, as they're not needed after the surgery. So once all of the bone cuts are made, we then typically use cement, although going to putting these implants in without cement, putting in the femoral component, which is metal, the metal tibial component, and then the plastic liner between the two. Here's how it kind of looks at the end, and here's someone that has one of those very bow-legged arthritic knees, worse here on the inside of the knee, and this is actually corrected, and you now have a straight, well-aligned implant after that surgery. And I do the arthroscopic surgery and see patients for arthroscopic surgery of the hip, knee, and shoulder, as well as shoulder replacement. If we think that you may better be suited for a knee replacement, I have 4 partners at New England Orthopedic Surgeons that all they do is hip and knee replacement, as well as revision knee replacement. And I would suggest, if you've been told that you are a candidate for a knee replacement or benefit from a knee replacement, to go to a doctor that has fellowship training in joint replacement and is going to have a lot of experience and high volume practice, and those are the patients that have the best outcomes with surgery. So we have 4 of these doctors, and I'm here in the Northampton office, and Dr. Michael O'Sullivan has started seeing patients in Northampton as well, if you're in this area. So I want to thank you all for your attention and listening to my talk today on knee pain, and I think now we can open it up to any questions that have come up.
Thank you very much, Dr. Cooper. That was awesome. I learned quite a few things, and I'm sure our audience did too. And I already see that there's a few questions popping in now. And we invite any of the attendees who have questions to type them in the Q&A box, and we'll ask Dr. Cooper. his expertise on them. The first one is, if you have a meniscal tear, are you susceptible to another one or other injuries in the future?
If you have a meniscal tear, they can propagate and get bigger over time. Not always the case, and they may not always be symptomatic. But that's the goal. If you've had a tear and we get to the point that we recommend surgery for, we try to remove all of the torn area and the unstable area to prevent further tears, or if we leave any areas that are still torn to propagate and extend. So if you have a meniscus tear, it is a potential that it could get bigger over time. Whether you're at risk for future tears, I don't think you'd be at any increased risk as opposed to how your knee was prior to that. If you have more advanced arthritis, though, then the meniscus is going to see increased load, potentially leading to more of those kind of degenerative tear patterns.
Thank you. Our next question is when should and shouldn't knee braces be worn?
Knee braces are another good option. I think there's very low risk to them. There have some that are very inexpensive, such as compression sleeves. And then we get to ones that have some more kind of support on the side. So if your complaints are more just pain, then maybe just a brace that applies compression will be helpful. If your complaints are more instability or feeling like your knee is given in or out on you or buckling, then more supportive hinge type brace would benefit. And then we even have some braces for patients that have arthritis on either the inside or the outside of the knee. So patients that have that bow-legged loss of the medial compartment, we have braces that are called medial compartment offloader braces, and they work to kind of push on the knee and bring the load more on the outside or central portion of the knee to take some of the pressure off the area where it's arthritic. Those offloader braces are typically more expensive. A lot of times insurers will require that we try a more basic hinged brace before getting approval for those unloader braces. But I think similar to some of the other things we talked about, like glucosamine, is that the braces are very safe. They can be effective, not for everybody, but there isn't much downside to trying a brace if you're having symptoms.
Thank you very much for that.
Mhm.
The next question is this person's had some difficulty going up and down stairs and had x-rays taken and was told arthritis, but now their thighs are hurting them and they're wondering if it could be something else.
It's probably related to arthritis in the knee. Sometimes you can get referred pain or pain kind of radiating up and down the leg. If it's thigh pain, it's possible they could have hip arthritis as well, or even maybe sometimes arthritis in the back can pinch the nerve roots in the back, causing sciatica type symptoms. So thigh pain could be a lot of causes, but probably most likely it's just related to the arthritis in the knee and some referred pain up to the thigh.
Thank you. Next question. Does arthritis affect both knees equally?
Many times we do see symmetric arthritis patterns. Most commonly, it's that bow-legged appearance where we lose the cartilage on the inside of our knee, but not always. Sometimes patients can have on one side of the knee where there's a bow-legged appearance, and on the other side, the knock-kneed appearance, and then we call that a windswept deformity because it looks like they're about to get blown over by the wind. So it's not uncommon to see symmetric arthritis, but it can also affect one joint and spare the other joint. The other interesting thing is that patients can have arthritis and be asymptomatic, or we see this every day where patients come in for right knee pain, and we will typically get x-rays of both knees, and the left knee could be just as arthritic or even more so than the right side, but asymptomatic. So it's interesting when we see that, but we can't really explain why that occurs. But just because you have arthritis, you might not even be symptomatic.
Huh, that is interesting. Thank you. The next question. How do you decide if your knee pain warrants further investigation? Start with primary care doc?
You could do either. Primary care docs see knee pain all the time. Like I talked about that very first slide, joint pain and arthritis is the second most common reason people go to see their doctor. So they see a lot of this kind of things, and all for most of the treatments besides surgery, a lot of that stuff can be done in the primary care setting. That being said, we see lots of patients that um, can just call, depending on your insurance, to see the orthopedic doctor without referrals, or a lot of times if you're at your primary care doctor and you have a lot of different other complaints, we just see the referrals for that. They maybe manage some of their other more chronic conditions, and then say new onset shoulder or knee pain, hasn't had any treatment. Go make a referral to see Dr. Cooper, and we see that all the time as well.
Excellent, thank you. Does the removal of the meniscus increase the chance of arthritis?
Yes. So for ideally, we would try to repair the meniscus and preserve it. And there's certain tear patterns that we can repair. And more and more, I think we are finding different ways to repair the meniscus and see that the repairs actually heal. But the meniscus is important for taking that load. So when we have to do a big meniscectomy and take a good portion of it, we will get rid of the pain that you're having now, but you may increase your risk for arthritis in the future. That being said, I think when patients have a lot of these tears that are degenerative, the meniscus isn't really functioning in the same sense that it was pre injury or that pre-morbid degenerative condition. So I don't know how much a lot of times when we have these really bad tears, the meniscus is helping, but there definitely has been studies that show that patients that have meniscus do increase the risk for arthritis. And before we were doing arthroscopic surgery, and even in the early phases of arthroscopic surgery, we actually were taking out the whole meniscus, and then we did find the risk for arthritis goes up. Now we're more selective, just trying to remove the areas that are causing symptoms and leaving as much as we can.
Thank you. Thank you for that. Next question. I've been told that running stimulates cartilage. Can you comment?
Well, I think that running can strengthen your bones and keep your knees strong. I don't know so much about stimulating cartilage. Um, I tell patients that are long distance runners, if they can run and stay active and not have symptoms, and it helps keep your knees strong and keep a healthy weight, and you enjoy it and you're not feeling it while you're doing it, or the next day, that it's okay to keep doing. But for a lot of people, they end up just kind of self-limiting and going to activities that don't hurt as much, like the biking, elliptical, and swimming. So I'm not sure if it's going to stimulate the cartilage, but it might not do any harm. But for a lot of people, they're going to just not be able to because it's going to hurt.
Thank you. The next question, what diagnostic tools such as X-ray, MRI, etc. do you use for initial diagnosis?
So the initial diagnosis involves X-rays, and a lot of times we get X-rays that might be different that the patients have previously gotten. So a lot of times, if you have X-rays when you're laying down or in the supine position, the arthritis doesn't look as severe. So we always get X-rays, including weight-bearing films, which better assesses the arthritis. We also do views with the knee slightly flexed, and that sometimes sees more subtle arthritis in the back of the knee. So X-rays is the definitely go-to treatment. And if we see someone that has very advanced bone-on-bone tricompartmental arthritis, there typically won't be any further imaging, because getting an MRI in that situation isn't going to necessarily change our management options, because in patients like that, they wouldn't be candidates for any kind of arthroscopic surgery. If patients don't have advanced arthritis or have minimal arthritis, a lot of times the treatment begins based on just X-rays if they don't have any of those kind of early concerning signs, such as an acute injury, feeling a pop, pain, swelling, or difficulty weight bearing. And we start the treatment based on X-rays or maybe cortisone injections or anti-inflammatories. And then if no improvement with that, the next step is getting the MRI.
Thank you. Next question, is there anything that can be inserted in replacement of the meniscus?
No, not yet. There's been some discussion of artificial devices that maybe look promising, but nothing, no artificial devices yet. In some patients, typically younger patients, athletes like college and high school athletes that have very bad meniscus tears that are not repairable or have failed repair, but still have preserved cartilage. We do meniscal transplant, which involves taking a meniscus from a cadaver that's matched to that patient's size and implanting that. That's not very commonly done, and very limited indications for that use.
Thank you. After a meniscectomy, I probably pronounced that wrong. Should you limit prolonged standing/walking during the initial post-op period?
Generally, I have patients walking on it right away with crutches, and I tell them that the goal is for pain-free walking. So if you are a week after surgery and the knee isn't hurting and you can walk without crutches, that's fine. In general, it takes a few weeks though that you're going to want to use the crutches and just kind of protect your weight bearing. And a lot of times we say use two crutches, and then after a week or so, maybe try one crutch and then no crutches, or maybe while you're in the house, try walking without the crutches. But if you have to do any long distance, extended standing, or more strenuous activity, to then bring the crutches back out. But there's no really restrictions if you're not having symptoms to put all your weight on it right away.
Thank you. This person had a medial meniscus tear 11 years ago, and they did PT, but now they're starting to get medial pain, and they're wondering if it's time to see someone or get a new MRI.
Yeah, I think I would, if it was me, I would try some of the things that they've probably already been doing, the ibuprofen, Aleve, some of the exercises, um, maybe modifying your activity or trying ice or just giving it some time. But if the pain is not going away, it's feeling like the same area as last time, then it probably makes sense to see your doctor. And in those situations, sometimes it can be a new meniscus tear and there still is preserved cartilage, and then we would go in and do a second surgery. Other times, those symptoms may mean that the arthritis has progressed and now it's more arthritis related problem as opposed to a meniscus tear. And a lot of the treatments are similar, but in those cases, we would kind of go the route of knee replacement as opposed to meniscectomy if you've failed kind of all the conservative treatment.
Thank you. This person says that they have been diagnosed with a knee that's bone on bone, and they have two meniscus tears, and they've been taking cortisone shots, but they're starting to get severe cramps in their leg, and they're wondering if this could be arthritis now.
Yeah, it sounds like it. If they've already been told they have bone on bone and the meniscus tears, it's probably more the arthritis kind of symptoms. And if they've had the cortisone injections but are not getting as much relief, then maybe considering those viscosupplementation or that hyaluronic acid injection. It's not uncommon that patients come with an MRI showing meniscus tears and some arthritis. And then there's a lot of situations where we kind of differentiate what would be the ultimate best treatment. But when we start to hear bone on bone, and probably have to look at the x-ray to make that assessment, it's probably more uh, arthritic kind of symptoms that if you're not getting relief with the cortisone injections or other types of injections, to consider knee replacement.
Thank you. This looks like it might be our last question. Will the MRI be the determining factor if surgery is necessary for meniscus tears?
So if we get the x-rays first, and then if we're thinking meniscus tear, we're always going to get an MRI. And if it shows a tear pattern that we can repair, like that posterior root tear or vertical tear patterns or some specific tear patterns, then I'll typically recommend surgery because we can repair the meniscus, preserve the cartilage, and we don't want to wait because it might be something that if we wait too long, it might not be repairable anymore. So in those cases, we'll typically recommend surgery early. For the more common type of meniscus tear, then it just becomes a discussion and kind of a case by case basis. How much is it affecting you? What have you tried? What are your goals and what are your expectations? So we get the MRI, but just because it shows a meniscus tear doesn't necessarily mean we're going to say let's do surgery.
Excellent. Thank you. I think we are at time for questions, but I want to thank you, Dr. Cooper,
Thank
for
you,
the
Sue.
great presentation and answering all these great questions. We appreciate you so much, and we hope we can get you back again sometime.
Yeah, this was great. This was a lot of fun. I want to thank everybody for tuning in, and thank you, Sue, for arranging this.
We have recorded the event, so if anybody would like to view this again or share it with their friends, we will have it available at baystatehealth.org. So thank you, Dr. Cooper.
Thank you. All right, have a good night, everyone.